Ehi, buonasera, grazie amico per tuo tempo e tua perseverança.
Boa
Grazie.
tarde, Marcelo, é um prazer. Boa tarde a todos os parceiros brasileiros.
Isso. Que bom que você está bem, com saúde.
Todo jóia. Mas o senhor sabe que meu português é muito fraco, então acho melhor falar inglês.
Seu português é ótimo, but let's go and speak in English. So, Germano, thank you again for being with us. Spend your time. I know how busy you are, and I know how terrific was the time, the tragedy was in Milano. So thank you very much. And to begin, tell me one thing. How big is Milan? I mean, the whole metropolitan area, how many people live?
So our metropolitan area has about 3 million people.
3 million people.
3 million, yes. And the region Lombardia is the largest region in Italy, and it's 10 million people.
10 million people. So it's a large population. And how many beds you have in your hospital in San Raffaele? How many beds?
So around 1,500. Around 1,500, yes.
1,500. So it's a big center. And,
it's a very large center.
Yeah. So when I mean, I'm not sure about yourself, but when the COVID starts in China, in Brazil, at the beginning, we were not aware of the size of the problem coming. I mean, like a tsunami that was far away. We do not imagine how big it was. And how was your feeling about that in the beginning?
Well, I think that everybody was in the same situation. We thought that we were going to deal with something similar to SARS, to the swine flu that we had in the previous year. So we thought we were relatively well prepared for this kind of emergency, but when it actually struck, it did it with a violence, a virulence that was totally unexpected. And as you know, the initial Italian outbreaks were several weeks ahead of the other European ones and of the North American ones. So we kind of have been in first line in this battle, and we had to do things
to learn, to understand.
Yes, absolutely. And certainly in the very initial stages of the outbreak, especially in the smaller local hospitals, there has been a lot of issues because in the beginning, patients with respiratory distress came in such an overwhelming way that they were mixed up with other patients in the emergency room, and so this probably helped spreading the epidemic in the very first days. And then the outbreak was just devastating, with number doubling up every day until we had about 5,000 new infections ascertained every day. And then, thanks to the social distancing and the other measures I'm sure you are well aware of, there has been some very good results in containment, and now we are in a phase, hopefully, of reopening the country to a more reasonable lifestyle, and the situation in the hospital is not so terrible anymore.
Good, good. Tell me
actually,
one thing.
In this stage, we are actually closing down the special COVID facilities that we opened very quickly in the first weeks after the outbreak.
Good, good. So tell me one, just for curiosity, how many people in the vascular group get sick?
So we have around 20 20 doctors plus 7 or 8, I should say, residents. And quite interesting, we had 3 cases among the residents, and we had no cases among the senior doctors.
That's
so I don't know if this reflects maybe more direct exposure to the patient, you know, when taking the patient history, which is a job which is done by the residents, or doing the initial physics, or maybe lacks experience with the protections. However, thanks God, all the cases had a very happy solution.
Yes, you know, in my hospital, I would say that almost every doctor from the intensive care unit, they got sick. But I would say also that 99% of them got treated at home. In my team, in the vascular team, 3 nurses and 4 guys in the staff get the disease, but nobody goes to the hospital, including me and Tatiana. We got tested for immune in the EGG. And we are reactive, but without knowing, we never had any symptom. So I probably got that in the hospital, got that from the hospital to home, but nobody feels. We are very lucky, I think.
Yes.
So, as we are talking about vascular problems, vascular people, etc., here they call us mostly to put catheters for dialysis, to see catheters in the arterial lines, but we also see not a few, but to see quite a lot of people with deep venous thrombosis, pulmonary embolism, and we need to put filters because they have to stop the heparin, and I also see some thrombosis of the femoral artery with no disease before. So what the most common vascular problem you are called to help the guys in intensive care?
Yes, Marcelo. So first of all, let me just very briefly explain to you how the COVID emergency changed the organization of the healthcare system in our region for the surgical specialties. So what happened is that the regional government decided to appoint 4 large hospitals to become hubs for cardiovascular surgery. And each of these 4 hubs would then serve about 10 spoke hospitals. In other terms, all the smaller hospitals are not doing any cardiovascular surgery anymore. They can just concentrate on COVID, and we get referral. The hubs get referral from the smaller spoke hospitals for all the vascular cases. So we completely stopped our routine cases, and we are just serving the region as a hub for cardiovascular surgery. So all the patients that would have gone to this smaller hospital are actually coming to us now. So we are just doing the urgent emergency cases. So this is as far as local regional organization is concerned. And I must tell you that we were extremely surprised of what thing happened here, because with this kind of organization, we expected to have millions of patients coming in with ruptured aneurysm, with strokes, with a lot of problems. And instead, in the first days, we have seen very, very few patients. And so this reflects something that has been seen also by cardiologists, also by general surgeons. The issue was that people was scared to go to the hospital. They
That's
were
true.
just they were terrified by the news that they were seeing on the news, by the fact that they thought they would get mixed up with COVID patients. And so people would just stay at home, maybe die at home, have their heart attack at home, have their ruptured aneurysm at home. And the only patients that we were seeing in the first days were patients with very advanced limb ischemia. So lots of patients with gangrene, lots of patients with chronic and acute or acute on chronic ischemia. So these were the patients that we started seeing in the first few weeks, in the first few days and weeks after the beginning of the outbreak. So this was really very unexpected, very unexpected. And then, of course, things started changing. People realized that it was actually safe to come to the hospital, that we have special dedicated routes within the hospital, so there is no physical contact from the COVID and non-COVID patients. And then, of course, we started getting patients with vascular complications of the COVID SARS pneumonia. So this we have seen both in the arterial and in the venous aspect. We have seen patients with coagulopathies. We have seen patients that don't respond well to heparinizations. We have seen many peripheral ischemias, and therefore we started looking also for deep venous thrombosis systematically in all COVID patients. So in the I would say second month after the beginning of the outbreak, when we started realizing that thrombosis was a big part of the COVID-related syndrome, we started giving duplex ultrasound to all patients with COVID, either in the wards or in the ICU. And we found some really interesting results. And we have seen that the percentage of DVT with no symptoms was in the range of about 15%, 15. So this is way more than you would expect for similar bedridden patients with other diseases or even with pneumonia, but not COVID related, where the expected rate is about 3%. So these are really quite worrisome findings, and of course we are trying to make sense, pathological sense out of this, which is obviously not easy.
So let's say for patients that, I would say the majority of the patients have the disease in a very light way, and they stay at home.
Yeah,
and
generally
so,
speaking, yeah, of course.
Yeah, and for those who goes to the hospital because they are becoming more sick, so at the beginning they receive prophylactic heparin, and if they find thrombosis, full heparin.
So in our situation, we give unfractioned heparin to ICU patients, but low molecular weight heparin and prophylaxis to patients in the surgical wards.
So
and post-surgical patients would also, in most instances, receive IV heparin. Yeah.
So even if the patient, you could not find the deep venous thrombosis, but the dead dimer goes higher, you just go and anticoagulate him in time. Full.
Yes, that would be our, unless of course there are some formal contraindications to anticoagulation therapy.
Yeah. Well, I know we as vascular surgeons, we are not involved in the front line really treating the patients, more the anesthesiologist, the intensive care guy.
Absolutely.
Yeah. So, but do you know what they have this special protocol for the patients now? They give like this hydroxychloroquine or azithromycin, or do you want to talk about that, or you are not aware of their protocol?
So you see, this outbreak has been so violent that things have changed in an extremely quick way. So as we are, we are an academic, we are a research hospital. There is a number of therapeutic protocols that has been tested, that are tested right now, and this situation, changes by the week, by the day. So in the first few weeks there was this chloroquine, but then very quickly the focus, at least in my hospital, has been to other anti-inflammatory drugs, especially drugs that block the interleukin-1 pathway, such as anakinra and others. So
Sure.
there are several protocols that are being tested right now as we speak. There are already a number of articles that came out from San Raffaele on this kind of tests, on this kind of trials, including one that was published just a couple of days ago on Lancet Rheumatology. So I am sure that anybody who is specifically interested on this new drug test can find really a lot in the literature, because now there is an extremely rapid pathway for publication, online publication on this topic. So as soon as the data is available, they get published really very, very quickly.
Good.
So I think that the literature is just the best source of data for anyone who is interested in this.
Yeah, for sure. And I heard that I spoke with Stefan Hollon from Paris a week ago or two, and he told me that he saw some acute thrombosis of the aorta. What I have not seen here, but have you seen that large vessel obstructions?
Iliacs, yes. Iliacs, yes, we have seen.
And how you treat them?
Well, surgically, usually surgical. In some specific case, you can use thromboaspiration. It depends. In most of the cases, they are already very sick, very heteromassic aortas, and the acute thrombosis is on top of some old atheroma. So it's not always possible to obtain a solution endovascularly, and in many cases still you need some open surgery.
So at the beginning you mentioned that now you are closing those special units for COVID patients, and you are restart your vascular program. So yes. I spoke also the other week with Oderich at the Mayo Clinic, and they have a protocol. I'm not sure if they change, as you said, with this COVID, things change day by day.
Very quickly, yes.
Yeah, very quick. But he said me for admitting patients for elective surgery, admitting that they are not, suppose they are not COVID patients.
We test every single patient. Every single patient that comes in is tested, and he's either COVID, non-COVID, and they follow two different pathways.
But at the Mayo Clinic, they test the CPR, and also they get a CT scan to see the lungs in some asymptomatic patients. I'm not sure. You do CT scan before, so patient
CT
goes to the hospital.
is not done as a routine test. It's done only with a clinical background.
Yeah, I understand. There is a friend of us here. He's a cardiovascular surgeon from Belo Horizonte, Leonardo Ferber. He asked you if you saw any Kawasaki syndrome.
No, we did not see any of those. No.
No. Yeah. We saw some reports, but here also we don't see a lot. For somehow also the kids, the children, are not the, let's say, the target of the disease.
Yes, thanks God, children has been quite spared from this virus. Now I think that one of the biggest problem is to return to normality, because now this COVID outbreak is making a lot of victims in people who don't have the COVID because they die of their own vascular disease. This is a very big problem now. We have had patients in waiting lists for aneurysms that have died due to ruptured aneurysm while waiting, and still there is a very big fear in patients to come and have their cardiovascular condition fixed. And also another big problem, at least in this country, is that there is still a prohibition of traveling between regions. So we can travel within our own region, but we cannot travel among different regions. It should change in the next 2 weeks, but still we are in this situation. So in Italy, for some very high level specialized surgery, people tend to come to referral centers even from other regions. This has not been possible in the last 2 months. So I'm sure that we have lost a lot of patients because we have not been able to see them.
Sure. And I spoke with other Asian, with Stefano Hulon, and they both said the same. And now they have a list of patients, and they have to call the patients to come in and explain them by phone. You can come in, you'll be safe, and it's different. Usually the patient looking for you, but now we have to tell them, you can go, you can come, it's safe now. You have to explain the patients. Is that what you said?
It's very similar, yes.
Yeah, it's amazing. And I saw in the news that in New York, the mortality for infarctus at home was, let's say, more than 100% higher now.
Oh, yes. A lot of patients have been lost for not seeking prompt treatment for their cardiovascular disease. Same for strokes, same for aneurysms. Absolutely, I agree with you. Yeah.
People, I would say, they are not being well informed. There is not a balance. I mean, what they see in the news is like to be scared. So I don't know how to have equipoise. So
it is very, very hard to have balance people on the news, especially because in the last 2.5 months, whatever TV channel you switch on, there is somebody speaking about COVID on the news. And you can be a good doctor, but not necessarily you are an expert in the matter. Even if you are a virologist, it does not imply that you are a good epidemiologist.
That's
I mean,
true.
the fact that you know the animal, you know maybe how to treat it, how to not treat it, does not necessarily mean you have ideas on how it's going to spread. You know, epidemiology is more similar to meteorology than to virology. You have to make forecasts on incomplete data. You have to make a lot of mathematical numerical simulations. The main difference between the meteorologist and the epidemiologist that the epidemiologist can change the thunderstorm with his actions. You know, if you put the right measures, you can really change the outcome. The meteorologist can just tell you to brace for the thunderstorm, and that's it. But we hear a lot of unbalanced news about this. It's certainly news, fake news, stupid reports have done a lot of damage to the healthcare of the people.
That's true. That's true. Just so I'm not sure if you practice any sports, but spoke with the Nicky Morrison from New York and also Stefan Hollon from Paris. They both, although the city was closed with a quarantine, they were allowed to practice sports. I mean, in the Central Park and even in Paris for an hour outside and go and for a run and walk a little bit and go back home. How was in Milano? Was totally closed. We could not.
So the situation during the hard part of the lockdown that was for about 1 month, it was forbidden also to go out jogging and bicycling. Everything was forbidden. So it was just stay home. Now we are in so-called phase 2, so you are actually allowed to go out to practice outdoor sports as long as they are not team sports and as long as as you don't have gatherings. So you can run, you can bike, but you cannot have a group of people doing it.
And to do that, you have to use masks?
Well, so the regulation for the masks is that you should wear them indoors. So outdoors, it's not mandatory to wear them. But of course, if you are queuing to go to the supermarket and there's 100 people,
Estamos com um problema aqui de conexão, mas acho que já vai voltar. Perdemos você aqui um pouquinho, Melissano. Perdemos o sinal do Melissano. Mas não saiam daí não, que eu vou contactá-lo pelo WhatsApp para ver se é algum problema local lá. Não cai não, pode entrar no WhatsApp. Ok? Voltou, está voltando agora o sinal, tinha caído o sinal. Nosso sinal está variando um pouquinho, não estou ouvindo bem.
Okay, now I can see.
No, yeah, good. You hear me?
Yeah, sure. It's okay now.
Sure. So, you said that if I'm going to supermarket, I have to use a mask because I'm supposed to meet many people. But if I'm just running alone, it's not mandatory.
Yes, that's the idea.
Good, good. So,
unfortunately, I think that the biggest risk will still come from gathering parties. Young people, they don't realize that even if they get the virus and they don't get sick, then they still go home and they give it to their grandparents and they die. So we will have to see in this phase 2 what is going to happen. And there is one unfortunate situation is that when you change the public policy, when you change the regulation, you see the effects after 2 weeks. So it's not that we change the regulations now and we see the effect tomorrow. What we are seeing now is the results of what happened socially 2 weeks ago. And therefore, we try to do this phase 2. We try this loosening up of the lockdown, and we shall see what happens in a couple of weeks, if we still get a nice reduction in the numbers, or if they go up again. If you have a second spike, then unfortunately something different will have to happen. But of course, on the other hand, we have really a very, very struggling economy, and there's people that have very big problems to put lunch and dinner on the table. So these are also social and political aspects that cannot be ignored.
For sure, for sure, for sure. And as you mentioned, that comes to my mind, what do you think about the next meetings about vascular surgery? So Frank Witt meeting, it's a huge meeting in New York. Your meeting in December, it's a huge meeting.
Well, I have to tell you that I am a little bit skeptical that it will be possible to resume our old style of, getting together for medical meetings for, I would say, quite some time. I don't think it's nothing that we will see in the next few months, because first of all, it will have to be possible again to travel by air. We'll have to see how air travel is going to change, and then we will have to see how the regulation will be about gatherings of people. And then at the end of the story, even if it will be legally, technically possible, we should ask to ourselves if we really want to put 1,000 people in a room for the time being. So I am quite reluctant to think that we will go back to our nice real life meetings for quite some time, which is really a pity, because even if the web can be okay for teaching, can be okay to give a class for the students, but there's no way you can replace what happens in the meetings room, not in the auditorium, but what happens at the coffee break, when you really talk to your colleagues, looking at them in their eyes and exchange opinions, and tell them what your last terrible case or terrible problem was, and you get a good opinion, a good first-hand thought by someone that you rely upon. So this is greatly missed, unfortunately.
That's interesting. You mentioned that, but we are, let's say, a very small portion of economy. Let's put that in a big scale. What's the main income of France, Italy, Spain? Is the tourism. So if people are not traveling,
it's going to be a very, very difficult times for many people.
Yeah, because for hotels, for restaurants, for all the attractions that comes and make a chain together.
Absolutely.
A huge problem. Huge problem. I love Italy, you know that, and I can't see the Duomo virtually, but I can see virtually, but that's not the same thing.
Yeah. Unfortunately, we will have to be patient for some time.
Yeah, for sure, for sure. But so you how much would you say you're now doing your normal activity, vascular procedure?
About 50%. About 50% now.
50%. Okay.
Yeah.
One of our friends from here, Adalberto Araújo, you probably know him, in like Sergio Meirelles, also they sell. It's a very complicated moment. In Adalberto,
yeah, I can see the comments. I can see them.
Yeah.
And I totally agree. I totally agree.
Yeah. Well, so, but I know at San Rafael, as you said, is a research center. And I know...
say again, please say again.
You are a research center.
Yes.
So, many projects going on. So the study about Misage study, so how things are moving again?
Unfortunately, this COVID outbreak slowed down also all the research projects because while these trials, they are ongoing, but practically the recruitment of the cases has been very, very low in these months. So we have been doing a lot of library work. We have been doing a lot of statistical works on our data. We have worked a lot in the office. We have studied a lot. We are writing a lot, but unfortunately, the enrollment of patients for the new trials is very slow.
Yeah,
and
for sure.
I have heard from good friends that are editors of major journals that the number of papers that they are receiving is like double, because everybody have more time to study, to write, because they have less clinical work, unless you are directly involved in the COVID patients. But for the surgical specialties, more time to study and to publish, more work for the editors.
So for those people who are afraid of the COVID infection, do you think there is any difference in the endovascular or open surgery? If you propose then it's an endovascular, it's an open surgery, they are more afraid one of other, or doesn't mind if they go to the hospital?
So you see the problem, let me just change slightly the perspective. So the big problem is when you have a patient with COVID pneumonia who also has an emergency, yes, a vascular emergency. So of course, I would try to do my very best not to operate on a patient with a full-blown COVID pneumonia, because he has a fairly high rate of mortality even without my surgery, just from the pneumonia. So of course I really don't want to touch him, but some situations we have to touch them, because if it is a broken aneurysm or if it is a very severe ischemia, you have to treatment in spite of the pneumonia. And so of course the less invasive the better, but sometimes you just don't have an option and you have to try to operate them, and of course the outcomes can be quite bleak. So yeah, it's something we really don't like, but in a few cases we had to do it, and it is what it is.
So you are becoming to June, and then July, August, you're probably going to change new residents, and the program is going on?
Oh yeah, the program is going on, but all the teaching activities of the university are done online. Both the teaching and the exam, everything is online. So the only thing that is still going on is the resident doing clinical work. This they still do. but all the students, they don't come to the hospital. The medical students, they don't come to the hospital. And I think this will go on for at least a few more months.
A few more months.
Yes, yes.
Yeah.
Who wants to, to have a kid that is studying medicine and he dies of COVID? You really don't want this to happen. So,
Yeah.
And of course, we have, I didn't mention it because I think that, it goes without saying, but as we get into the hospital in the morning, we have our temperature checked when we go in, when we go out. We have to wear our personal protection equipments. So these are all things that I give for granted, but I think they should be done very seriously everywhere if this is still not yet the case.
Good. Yes, I think a teaching hospital, although the students not going to the school, the medical school, but the residence program still going on. So the residents, they are not workers of the hospital. Do they have to?
Oh, well, in a way they are. In a way they are.
Okay.
At least in my country, yes, because they get a wage, they get a salary from the state, and they are, well, it's part of their contract to do the clinical work.
Yeah, they don't need to sign a paper that I assume the risk and I'm okay.
It's no, it's not. It's not.
It's just part of the job.
Not. Yeah.
It's
just that we don't gather in the classroom all together. That's the only thing we don't do, So for the frontal lessons, we use the computer.
Good. So let's say in an open surgery, instead of putting 3 or 4 guys helping you to do a thoracoabdominal, you try to do less, 1 or 2, just less people in there.
Yeah, but it's still acceptable because there are not as many cases going on. So I think that the situation is acceptable. Of course, you can have an unlucky night when you have 3 rooms going on at the same time, then you can have an issue. But usually it's okay. So we just have now to hope for the best, hope that the social distancing did the trick and that we can go back to business as usual, because if this is not the case, it's going to be very, very problematic.
Probably we heard a lot about some vaccine. If you have any shot that could protect you, perhaps maybe we can have a normal life, but I don't know when we going to have that vaccine.
This will also take time, yes. And then, things are in real life, they hardly ever go like they should by the book. If you think, for instance, of the last SARS pneumonia virus, or the H1N1, at the beginning of the outbreak, it seemed to be very catastrophic, and then they developed the vaccines. And for instance, I remember Italy at those time bought some 4 million vaccines for the H1N1 SARS, and then the outbreak just took care of itself, and they were never administered. So it's really hard. We don't know. We don't know. It's really hard to know.
Yeah, I just also heard in the news that some countries in Europe will open to travel inside the Europe, not outside, but in Europe, Germany, France, and Italy. Do you think the borders will be open?
In Italy, we don't even allow people to travel between regions in Italy. So unless you have some very, very serious reason. And usually, if you do travel, you get quarantined where you arrive. So really, traveling is still not. I am seeing here that some some participants are experiencing some issues
With
on
Instagram.
I don't know.
Yeah, it happens. Unfortunately, sometimes it happens. It depends on the connection, and you know.
Okay.
Yeah.
Anyway,
But
I hope that our friends were not too bored from this conversation. I hope that we got some insight from this part of the world, since we are a few weeks in front of other countries. And it is now almost 10 p.m. Here in Milano. And so I think that it's time for me to go home. And I would like to thank you for hosting me in this live conversation. And I wish all our friends in Brazil all the best. Fica com Deus e grande abraço.
hope to see you soon. Take care
Absolutely.
of all our friends. And grazie mille.
Ok, un abbraccio.
Abbraccio.
Adeus.
Bye.
Ciao.